Right, welcome. And so I got told I'd introduce myself. So my name is Ole. I'm the SCD of diabetes over in Green Lane. And I will rush you through a few little things about, what we're doing forward slash, probably this one here. A few things that go in line with the emphasis of these meetings. So really trying a little bit about practical tips how to do it from a doctor's perspective. So you all probably know this one. Caring for someone with diabetes is complex, is tricky, and there are a few important things. As we just heard, words matter. What words you use, there's good evidence that it actually makes a difference. And our approach and attitude matters. There's a lot of shaming about weight. It's important to really be questioning oneself how to actually address this one. And of course, when someone comes to the praxis, there's always the question whether the person comes for a weight-specific reason or whether the patient comes for anything else. So it's a way how you figure this one into your consultation. And of course, people tried it several times before they see a doctor. But it can be rewarding, and actually what I want to show you is there are data that you actually can use a combination of diet, lifestyle, medication, or maybe surgery as a top to make a difference. A great resource for primary care, which I in all of these talks really refer to, see from Dr. Sharma, that is available online. It's a resource from Canada, and it's a really great way of actually learning about obesity, very practical, more than I can give in this 20 minutes here. So have a look at it, 5 A's for obesity. And there it is very clearly stated, obesity is a chronic condition or disease, whatever you call it. I think condition is better because it doesn't have the disease focus. And if you really want to make a difference, you have to address it like a condition, like you treat any other chronic condition, whether it's diabetes, hypertension, dyslipidemia. You treat obesity the same way, and then it actually starts making sense. And of course, the aim is not about reducing the weight by itself. The aim, as we just heard now, is actually achieving a healthier patient. And that actually allows better adherence to medication, as we know. So the aim is to reduce obesity-related complication. And you probably already heard, you don't need to lose much weight to actually improve your condition. So with 5 to 10%, if you can achieve this one with medical and lifestyle changes, you can reverse or reduce your diabetes significantly. So therefore, it is important to actually talk about the complications, and that's just a quick slide in here. So you probably see that a number of cancers are associated with obesity, and that there are more than 100 other comorbidities, and of course, you know all the big ones that are associated with weight. So, and of course, we know that there's an increased mortality. Really, when your BMI goes above 30, the mortality starts rising for cardiovascular, but also for all other diseases. And it is why it's so difficult to treat, because it is inherited. And you see it. You see it in every families, so it goes through. There's genetics, epigenetics that really supports it. And of course, it is regulated via eating. And how is eating regulated? Between the gut and the brain. So there's a connection between the gut and the brain, neuronal, hormonal, which actually makes us eat and makes us overeat if this hormonal balance is disrupted. And that's really why it's a chronic relapsing. It's not because the people can't get it together. No, because they are driven to eat because of the dysregulation of the feedback loops. And that's where the medication comes in, where you basically tackle these feedback loops. So it means you've probably all seen this one before. So we pretty much on the bottoms there, number 3 in the OECD countries. So if you look at the men, I think we are pretty number 2, aren't we? So just a little stark reminder. The other thing, what is actually for me as a diabetes doctor even more important, more concerning, is a significant rise in type 2 in the young people. And as it's on the slide there, if you develop type 2 in your 20s, your morbidity and mortality is much worse than if you develop type 1 diabetes at the same time. or in any time of your life. So therefore, and these are the people who don't bother, who don't come, because the type 1s, they come, they want a good sugar control, they're engaged. The ones who have type 2 and obesity, they are actually the ones that are much harder to tackle. You probably all know this one from the practice. So that's just another slide. When you actually assess comorbidity, I try to put them into a number of groups, so mechanical, metabolic, cancer, psychological, functional, and mortality. And you can see on the slides, you will have access to the slides, just a little bit how different areas of the body are affected, and the numbers are the reduction with bariatric surgery there. That's a great little tool for people to look at. It's the Edmonton Obesity Staging System. It has 4 categories, so risk factors, symptoms, psychological, and functional. And you can stage severity there. And why it's important? Because it actually predicts mortality better than BMI. So a little bit what we heard before, so when you're healthy and obese, you probably have far less mortality than if you're actually unhealthy and obese. So before I come to the cases, 2 slides quickly about assessment. So it's important to have a structured assessment like any other chronic disease. I use some pre-assessment tools in the clinic. It's a comprehensive assessment in a multidisciplinary team, investigation and a management plan where you're supposed to agree on. What is quite helpful for a primary care setting is really that you can give these patients at the beginning, you develop a timeline, how they gained weight, what led them to weight gain, how old were they when they started, what allowed them to reduce their weight. It's a great little tool to understand the triggers for weight gain. And if you, of course, gained weight early on and you have a strong family history, and you're 40 and you're female, you probably need more than diet, because you know from this one that you need to address different people differently. So first case. If you have any question in the case, just raise your hand and interrupt me. So that's a case with a quite heavy lady. You can read that one off. She had an Edmonton obesity stage 2. She had an early onset of weight, and she developed type 2 early onset, as I just mentioned to you, significant risk factor. She has the acanthosis with the insulin resistance, and she has an HbA1c of 104, and she's, of course, driven to eat. And I always ask about eating pattern, because it gives quite a bit away what actually drives people for eating. So she's doing exercise and behavior. And now, the question is, when you see this case, what do you focus on? You basically focus on certain kind of things you want to evaluate from the history. Right? There's a genetic predisposition, there's a cultural component for her eating, but she can lose weight, and her type 2 is her main problem. And she had it onset relatively early, and she didn't have it for longer than 3 years. She has a few other complications, but not too many, and she has no significant abnormal eating. She's doing exercise and there's no depression. So her treatment is, of course, what you have available in primary care. It's metformin and vildagliptin. A GLP-1 agonist would be ideal because it would slow gastric emptying and also has a bigger impact on the hunger. But vildagliptin and metformin is available. She started a diet plan and was very engaged. And she didn't lose much weight, as you can see, but her HbA1c came down because she had relatively early onset type 2, i.e. with some medication and weight loss, even by minimal weight loss, you can achieve a significant improvement in HbA1c. And this case I saw a little while ago, just last week I saw a very similar case. So it's common, I think, and the evidence behind shows you that the studies about preventing diabetes, so that's the diabetes prevention trial, so 58% reduction in developing diabetes, so you can prevent it with lifestyle. And they had 10-year follow-up data, which basically show that you still can keep it off. You can prevent developing diabetes, that's what I'm trying to say. And the other study, there's a little online talk from one of my colleagues from the North Shore, I think this week, coming week, sorry, about a direct study which showed if you had diabetes for less than 6 years and you went on a meal replacement and you lost around 15% of your weight, you had a 46% chance of regression of diabetes. That's not reversal of diabetes, regression of diabetes. And they recently published the data on the 2-year, so they came down to 36% after 2 years. But it's still quite a significant regression of diabetes. Second case, this is a young lady with massive weight. And yes, these people come through the diabetes center. I last week had someone with 260 kilograms. So, and yeah, everyone knows that these people need more than just good advice. And of course, these people struggle. So she was too heavy for bariatric surgery, and bariatric surgery is the only treatment that would work. But you need to go down to roughly 180, 200 kilograms to go safely for surgery. So she had just recent onset type 2 diabetes, but she had long-standing weight problems. And there were severe eating disorders as well as part of this one. So nighttime eating, some people get up in the middle of the night and start eating. It's good to ask about it. Binge eating, feeling regrets, all these kind of things. Not feeling full after meals, having 2 burgers and then craving an hour later because of rapid gastric transit. And of course, then social bits come in as well. So financial tightness comes in there as well. So what's the message here? So she has only an Edmonton obesity stage 1. She doesn't have many complications, but for her, it is losing weight for bariatric surgery. So she needs a full MDT approach. So she needs a medical appointment, a dietitian, a psychologist. She needs meal replacement, and she needs to start a number of medication for weight loss. I want to say a couple of words to weight loss medication. That slide I just put on to you to remind you that it isn't willpower, it is physiology. And I don't want to talk you through this one, it just comes through the next slide. There's a number of hormonal pathways that really drive the eating behavior. And there are a number of treatments, some are available, some are still in the research, that actually give you these hormones. One of them is available, the GLP-1 agonists. So for her, we used one of the traditional medication that's available here. It's phentermine, that's basically a sympathomimetic, has also dopaminergic and adrenergic action. It works in the hypothalamus, and it has a long half-life. Important bit of phentermine is that you need to start at low dose. Please don't start phentermine at 30 milligrams. You can start it at 15 milligrams every alternate day or 15 milligrams once daily, and then if needed, you titrate it up, but most people do fine with 15. Some big people in this case probably need more. You avoid it if you have a history of cardiovascular disease, and there are a few other bits that you need to be aware of when you prescribe it. There are data, because phentermine is old, the data were small, so we don't have many data on phentermine by itself, but what we have is the combination of phentermine and topiramate. So that would be off-license script, and I currently writing something about this medication, how about off-license scripts, and it's very important to be very careful and document everything, because there's, of course, everyone's registration on the line, but this medication is overseas available as a combination of phentermine and topiramate, and you can see the placebo-subtracted weight loss is more than 10%. So that's just basically popping a pill, and you lose 10% of your starting weight. And this data is for 1 year, and these data work out for 2 years. So that is the low-dose duramine. So you have data available on this, on low-dose duramine up to 2 years. Another case. Do we still have time? Okay. This is a 58-year-old male with a significant number of comorbidities. So he has an Edmonton obesity stage 3, and he has cardiovascular disease, type 2 diabetes, dyslipidemia, as you can read, gout, fatty liver disease, obstructive sleep apnea, and of course joint and ankle pain with his weight. So he gained weight later on in life. He managed to lose weight with exercise, as it often is with the younger males, but he had several subsequent attempts. He also had a family history for type 2 and obesity and renal cancer, and you know certain cancers are associated with obesity, as I showed you at the beginning. And he has this kind of pattern of constant craving. There's people who can eat all the time. And he had a moderate diabetes control, a little bit fatty liver, and a low testosterone. That's a whole other issue in this age group. So what I always say is either measure or calculate the free testosterone, because males with obesity have a low total, but often a normal free testosterone. He had a low free as well. So the key aspects here are really later on weight gain, multiple complications. So as I mentioned at the beginning, we want really 5 to 10% weight loss. So we focus on his diabetes management. So he got dapagliflozin for SIGA, which probably a lot of you already prescribed, vildagliptin and exenatide. He got low-dose testosterone, obstructive sleep apnea treated, and we up-titrated his cardiovascular medication. And he used the intermittent fasting approach, which actually worked quite fine, especially people who have a busy lifestyle. And of course, what we do here is we're using diabetes medication a little bit broader, where we have the GLP-1s working on several parts of the body. We have the DPP-4 inhibitors. So we have basically trying, it's probably too much in the last 5 minutes to put it all together, we're trying to have different drugs that work on different parts to improve diabetes. And that's a talk in itself, but just to give you a little flavor that there are a number of diabetes drugs that can improve your glycemic control as well as your weight. And the one which it's a great drug to have is the GLP-1 agonist, which basically reduces hunger, increases satiety, slows gastric emptying, increases your insulin, and reduces your glucagon. So these slides are available. I won't labor you with the mechanism behind. To come to my last case, that's another little message I want to give there. This is a lady with a BMI of 48 and significant obesity-related complications, as you can see there. She doesn't only have type 2 diabetes, dyslipidemia, hypertension, vitamin D deficiency, which is common with obesity, gout. She had also PV bleeding, and so she was 67, so we were concerned about this one. She had ankle edema and couldn't walk very far. She had back pain and neuropathy that didn't really fit with the diabetic neuropathy. She had long-standing weight, recurrent weight cycling, and she didn't want bariatric surgery. She had a few abnormal eating patterns, mainly emotional eating and cravings. So here, really, the main focus is the long-standing medical history, the significant medical problems. So any obesity assessment has to assess all the medical problems and really trying to find something that will work for her. So what we did, basically, we started dapagliflozin, metformin, vildagliptin. We gave her a meal replacement. She managed to lose 20% because by this time we knew that actually what she had in her spine was a paraspinal tumor, and what she had for a PV bleeding was a small low-grade endometrial cancer. So she had long-term obesity, as I showed you at the beginning, is associated with cancer. So be aware, endometrial, ovarian, breast, postmenopausal breast, these cancers are associated with obesity. So it's important in these patients to actually keep a wide focus. And that's basically the medication we used here was naltrexone and bupropion, which is basically a combination of one which you use for anti-smoking and one for anti-weight. Both are off-license script for select patients in a supervised setting, but available again overseas in Australia, Europe, and the US. And that's what you can see with this medication. You see placebo subtracted roughly 6.5–7%. So yes, it has to be all three if you want to achieve something, That's what they had in the UK for the last 5 years, a tier system. And the specialist assessment tier 3 clinics in the UK are run in primary care. So what I make an appeal here is there is space for doing this one in primary care. And so we talked about treatments and medication as one, bariatric surgery balloons are in. I probably don't have to ask the question, but any hand, which one is the one out? Because when you do assessment for medication, you also assess medication that actually increases weight. So which one do you think is the odd one out? Shout it out. Pardon? Yeah, bupropion, exactly, you got it. Because that's all the other one, that's why I have it in, are actually increasing your weight. So that's why it's important to be aware of it. So leave you with the last slides, how to do obesity medication. So you reduce medication that can cause weight. You need to be aware that there's dual benefits. For example, Duramine and SGLT2 inhibitors work well together. You have medication that have dual benefit. For example, topiramate is a migraine drug, but it also works for weight management. You use a medical approach. You avoid any medication-only approach. That's where these obesity medication really come into disregard, where people basically only use medication, and that's clearly to be avoided. And you, of course, look into contraindication and side effects. You have tools to support adherence. You be aware of the stopping rules, and you have to document very carefully if you do off-license prescribing. Thank you.
Choosing phentermine, like there are patients who are not too much obese, but they are very much worried about their nothing else working for them, and no other treatment worked, so they are very much into phentermine as their first choice. Mm-hmm. Will you be liberal in giving them phentermine, or you will wait for a particular type of patient who will be more benefited by that?
That means, you can hear me, as I just mentioned, if a patient comes in your clinic and says, "Doc, give me some phentermine," I think you don't do anything good. And then you give them phentermine for 3 months and they do more weight cycling, you feel obliged to stop it after 3 months and you haven't achieved anything, right? So that's where it doesn't work. What you're supposed to do is you assess a patient and you say, right, I think you're keen to lose weight. Let us start with some dietary measures. You do the dietary measures, whatever it is, so whether it is meal size reduction, intermittent fasting, carbohydrate restriction, whatever the patient wants, and you aim for 5% weight loss. The patient comes back to you and said, "Look, I did it, but I'm really struggling with cravings here. I can't sustain it any longer." And that's when the medication comes in. You use then 15 milligrams of Duramine to maintain the weight loss and keep the motivation up. Why? Because it is easy to lose weight. It's difficult, as everyone knows, to keep the weight off. And once you have lost weight, your metabolism slows down and your hunger goes up. And that's a great way to when you start this medication.
I just have a question regarding the ADHD medication, because it kills the appetite, kids don't eat. Has anyone looked into that as a weight loss medication?
Ritalin.
Yeah.
Ritalin. Ritalin is not licensed in this country for anything outside for ADHD. Yes, it can reduce weight, and it is overseas licensed for binge eating disorder. So in the US, they have it, I think, for binge eating disorder. But it is clearly a drug I would not touch for weight management. Because, you see, one thing you have to be aware, there's a cultural component around. Most people don't prescribe Duramine, right? So most people are quite still in the mindset weight loss medication can do harm. And yes, it did. When we had the fen-phen, a lot of things gone wrong. And the problem is patients will push you for anything. And you will have to bear the responsibility of doing something where you go out of the ordinary what your colleagues do. So therefore, I would clearly stand here and say, don't use this for overweight management. There are simpler ones. Take your fingers off anything like this.
Sorry. Thanks, Ole. It's a great talk. I was interested to see that your hypogonadic man is on low-dose testosterone, and I wondered what your thoughts were about A, what is low-dose testosterone, and B, is it a temporary treatment until he loses weight, or it's a long-term treatment?
Okay. So that's basically a question about obesity-related hypogonadism. As I said before, a lot of men who gain weight, especially in midlife, have low total testosterone because their SHBG, the sex hormone binding globulin, is also low. And SHBG goes inversely proportional to weight. So obesity causes low SHBG. So when you measure their free testosterone, that is also often normal. If your free testosterone, either calculated or measured, is low, then these people have secondary hypogonadism. You then can measure the LH and FSH, and in these people you find often a normal or an inappropriately normal LH and FSH. So if you had, for example, testicular failure, you would have a very high LH and FSH. If you have pituitary failure, you would have low. So here you have an inappropriately normal gonadotrophins for lowish testosterone. And yes, you can treat these people if they have it. I try to keep them at the lower end of the normal range because, especially if they have cardiovascular disease, there's lots of evidence that it actually can increase your cardiovascular risk. There's a lot of work which came recently out of the Endocrine Society looking into this one because, again, there is a big drive in the US for these men's health clinics that prescribe testosterone just for getting men fitter. And that's clearly a risk to be aware not to do. But if you have a documented secondary hypogonadism with low free testosterone, you can give testosterone either as tablets or as patches.
Okay, I think we'd better bring the session to a close. So thank you very much.